Good morning. I'm Dr.S.REENIVAS, Professor and HOD of the Medicine Department, and I'd like to thank Vishnu Teja for giving me this opportunity to speak on a topic, a localization of lesions in the central nervous system disorders on behalf of Hamsa. Well, this is one of my favorite topics. Usually, day in and day out, you see in the medical wards where people come being brought with hemiplegias, people coming with, brought with in an unconscious state. So, if you are able to decide where exactly the location of the lesion in the nervous system, the treatment modality will definitely vary, and you can salvage the brain to some extent and the spinal cord to some extent, and you can give a good prognosis to the patient's relatives as well as to the patient. So the anatomic diagnosis and etiological diagnosis, they aid, they support, and complement each other. See the words I have used here. They aid in the diagnosis, they support the diagnosis, and usually they complement each other. And the central nervous system comprises of the brain and the spinal cord, and the peripheral nervous system is anything outside the brain, including the autonomic nervous system and the cranial nerves. So if at all you want to know what exactly happens as far as this cerebrovascular accident is concerned, so-called anatomical structures should come into your mind as soon as the patient has arrived. So we defined it as the cerebrum, the midbrain, the pons, the medulla oblongata being the brainstem, then the cerebellum, the spinal cord, which has the cervical, thoracic, lumbar, and sacral regions of the spinal cord. As you can see on the right-hand panel, a beautiful diagram has been depicted where the cerebrum is separated from the midbrain, and the pons, and the medulla, and then you can see the cervical as well as thoracic, lumbar, sacral regions of the spinal cord, and a bit on the back is the cerebellum. So if you come to the cerebrum into consideration, usually it contains the cerebellum hemisphere, the corona radiata, the internal capsule, the midbrain, the pons, and the medulla. And if you come to the spinal cord, it contains the anterior root as well as the posterior root, then the trunks, the divisions, the cords, the branches, and the peripheral nerves. So if you come to the cranial nerves, there are 12 cranial nerves replaced together, and the cerebellum depicted here, extrapyramidal system, and then the autonomic nervous system. So you have umpteen number of organs as far as the central nervous system is concerned. So cranial nerves, cerebellum, extrapyramidal system, autonomic nervous system, and apart from that, we have to add a bit on the bladder as well as the bowels. Now coming on to the etiological, when the patient is brought with a neurological system disorder, the etiological factors can be umpteen. They can be congenital. You can see a hydrocephalus patient here, a small baby. And then the acquired causes. Then you can see a traumatic, where a trauma, an injury to the head can produce trauma. And then you can see the inflammatory. Most often we come across is the meningitis as well as encephalitis. Then neoplasias, any tumors in the brain, and blood vessel. That's vascular. Most often we see more than 95% of the cases we see in the wards are comprised of the cerebrovascular accidents only, where the patient can have an ischemia or the bleed or an embolic stroke. And then we can see the endocrinal causes where the pituitary can be damaged, and then the degenerative causes. Most often we see the so-called Alzheimer's disease, a degenerative disorder, and motor neuron disorders. So the best way to remember, most often I teach you in the wards, is CATIN BED, that's cat in bed. This is the best way to remember. So I have depicted here the congenital acquired traumatic, inflammatory neoplastic, vascular or blood vessel, endocrinal and degenerative. So these are the etiological factors. When the patient comes to you, is brought to you, we have to define what exactly the etiology comprises of. Depending on that, the treatment varies. So if you see the blood supply to the brain, this is what you have studied in the anatomy itself, the circular Phyllis. So this, if you are able to register in your mind the circular Phyllis and its branches, it will be easy for you to define what exactly is happening. So we have two types of systems as far as the blood supply is concerned. The anterior system being the carotids and the posterior system being the circular Phyllis, where you have the posterior cerebrals and the cerebral arteries, vertebrobasilar as well as the carotid system. So if you come to the lobes of the brain, this is how it is defined: the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. So these are the four important structures in the brain where, depending upon which lobe is involved, the presentation also differs from patient to patient. So if you see the representation in the brain, on the medial surface, you can see the leg, foot, and ankle area. And as you come towards the lateral surface, it's the hand, and then down below towards the lateral area, you can see the so-called face as well as the mouth, tongue, etc. And down below, you have the lateral fissure. The other structures are depicted. And as you can see, the hands are given major representation as well as the face and the tongue. These are the structures we often use. So tongue has been depicted given a large area because over a period of millions of years, human beings have evolved. And so the structures we often use most are represented more in the brain. So when you come to the lesions, and we often divide them into two major categories of signs. One is upper motor neuron signs and lower motor neuron signs. What are lower motor neurons? In the brain, it is the cranial motor nuclei. Say, for example, if the facial motor nucleus is involved, you will get lower motor sign. If the fifth nerve motor is involved, that's cranial nerve is involved, you'll get lower motor. Above that, we say it is upper motor neuron. And in the spinal cord, the anti-horn cells are said to be the lower motor neurons. So the upper motor neurons have always a control over the lower motor neurons. And depending upon the presentation, we can say whether this is a lower motor neuron sign or an upper motor neuron sign. The first important thing is wasting. In upper motor neuron lesions, we don't have any wasting of the muscles, but in lower motor neurons, over a period of days and weeks, there will be a definite wasting. Fasciculation. In upper motor neurons, fasciculation will not be present, but in lower motor neurons, fasciculations are definitely present. The tone is increased in upper motor neuron, whereas in lower motor neuron, it will be decreased. Power, it's decreased in upper motor neuron, and in lower motor neuron also is decreased. It's wrongly depicted here. Power decreases in both conditions, as well as upper motor neuron as well as lower motor neuron. And reflexes, they are exaggerated. Deep tendon jerks are exaggerated in the case of upper motor neuron, and in lower motor neuron, they are either absent or else they'll be decreased in intensity. And a plantar is always upgoing in upper motor neuron, and a lower motor neuron, it's flexor or equivocal. That means there won't be any response. So this plantar extensor or Babinski sign we often teach in the wards has revolutionized the entire neurology. So depending upon that particular sign, we can define whether this patient is an upper motor neuron or a lower motor neuron lesion. So this is how we have to elicit the normal plantar response here. You can see the flexion on the left-hand panel in the lower diagram, and extensor, you can see the patient will have upgoing great toe, extension of the great toe, and fanning of the other toes. There will be dorsiflexion of the ankle, flexion at the knee, and the hamstring muscles contractions. So these are the 5 factors which say that the patient has an upper motor neuron lesion. So this is the one which has revolutionized. So we have to always be indebted to Dr. Babinski. And the clinical presentation, how the case with the central nervous system disorder is present. One is hemiplegia, second, of course, is crossed hemiplegia, and third, of course, is facio-brachial monoplegia. So this is how a patient with hemiplegia looks like. Most often we say the patient has weakness of left upper limb and left lower limb, or else right upper limb and lower limb. But remember, hemiplegia means right from top to toe. The patient will have weakness because the representation in the brain is more of the limbs rather than the trunk. We often say the patient has upper limb and lower limb weakness, but in fact we have to use the term it is weakness of one half of the body, including the face. That's very, very important. So this is crossed hemiplegia, where you can see here the blue panel. You can see here the patient has involvement of right brain damage. When the patient has brain damage here, the right side brain damage will produce hemiplegia on the left side, and left side brain damage will produce hemiplegia on the other side. But if the cranial nerves are affected on one side, cranial nerves on one side with hemiplegia on the other side, we say this is a crossed hemiplegia. So including the face, right from top to bottom, if one half of the body is involved, it's hemiplegia. If cranial nerves are involved on the right side and hemiplegia on the left side, that is known as crossed hemiplegia. There is a third entity known as facio-brachial monoplegia, where the face as well as the arm will be involved, but the lower limb will be spared. This is known as a facio-brachial monoplegia. You can see here where the patient has a deviation of the angle of the mouth to the right side. That means left half of the face is damaged, and you can see the left upper limb is weak. So this is known as a facial brachial monoplegia. It's a special condition where an artery which is destined to supply the face and the arm, and which is a branch of antecerebral artery, may be damaged. This is known as a recurrent artery of Hubner, Hubner. So recurrent artery of Hubner damage can produce facio-brachial monoplegia. So coming to the corticospinal or the pudendal tracts, if they are involved, the skilled, intricate, strong, and organized movements are depicted by the corticospinal. They are controlled by the corticospinal tract. And if they are involved, loss of skilled voluntary movement will be present, spasticity will be there, and changes in the reflexes will be present. So you can see here, corticospinal tract defectiveness can produce loss of skilled voluntary movement, spasticity, as well as reflex change. And if the pyramidal syndrome is involved, system is involved, usually the function of the extrapyramidal system is the fast fluid movement that the corticospinal system has generated. So the corticospinal tract generates the movement, and the fluid movements after being generated will become fast as well as smooth. So that is depicted by the extrapyramidal system. And suppose if it's damaged, the defectiveness can produce bradykinesia. The fast movement will be lost, rigidity will be present, tremors will be there, and chorea may be there. These are all involuntary movements. The bradykinesia most often we see is in Parkinson's disease. And chorea most often we see in rheumatic fever. And the third important thing is the cerebellum. So cerebellum usually is a coordinating, smooth, and learned movement initiated by the pyramidal system and enforced in balance control. Now we can see here the corticospinal tract, extrapyramidal tract, and the cerebellum, they act in a conjoined manner. So if all three are present simultaneously in a healthy manner, then the movement will be very fine. So defectiveness of the cerebellum can produce ataxia, fast pointing, action tremor, and incoordination. So each and everything, all these systems are very, very important in the corticospinal, extrapyramidal, and cerebellum. They complement each other in producing a very fine movement as far as human beings' movements are concerned. Now we can see the corticospinal tract. They usually start in the bed cells, and which are like pyramids. So that's why it's known as a pyramidal tract, and usually they form a pyramid at the medulla. That's why they are known as pyramidal tract. They start in the pedicentral gyrus, They usually descend down through the internal capsule and they come down to the midbrain, pons, and medulla, and then they cross towards the opposite side. That's why the left half of the brain controls the right half, and right half of the brain controls the left half. And what is hemiplegia? So any lesion above the level of the midbrain. See, the third nerve nucleus is situated in the midbrain. The sixth and seventh and eighth are located in the pons, and the ninth, 10th, 11th, 12th are located in the medulla. These are the cranial nerve nuclei. So in the start of the lecture, I've told you, if the patient has a cranial nerve involvement, it indicates the patient definitely has a lower motor neuron. So anything at the level of the midbrain will produce a lower motor neuron cranial nerve damage. Above that, any lesion can produce a definite upper motor neuron lesion. So any lesion above the level of the midbrain is known as hemiplegia on one side only. That is, half of the body is involved right from top to bottom. So the patient has come to you right from top to toe, one half of the body, right from the face, the arm, the trunk, as well as the lower limb are involved. We say it's hemiplegia, and blindly you can say the patient has a lesion in the above the level of the midbrain. The clinical features are loss of voluntary movement opposite to the side of the lesion, wasting of the muscles is absent, hypertonia of the anti-gravity muscles. So here the upper limb will have flexor hypertonia. So flexors are said to be anti-gravity muscles in the upper limb, and extensors are said to be anti-gravity muscles in the lower limb. So the patient will have flexor hypertonia in the upper limb and extensor hypertonia in the lower limb. And the deep tendon jerks are exaggerated, and the plantar is an extensor. So these are all the features of any case of hemiplegia. Okay, hemiplegia with a plantar extensor with exaggerated tendon jerks and wasting is absent, and the patient will have hypertonia. And what is crossed hemiplegia? Just now I told you, anything at the level of the midbrain or the pons or the medulla. It damages the cranial nerves on one side and causes hemiplegia on the other side, because the pyramidal tract usually goes towards the opposite at the level of below the medulla only. That's why the patient will have involvement of cranial nerves on one side and hemiplegia on the other side. This is known as crossed hemiplegia. As you can see, the red lines are depicted. One is the midbrain, second one is the pons, third one is the medulla. So lesions involving the brainstem. Since the cranial nerve nuclei are situated in the brainstem, lower motor neuron involvement of cranial nerve nucleus on the side of the lesion and hemiplegia on the opposite side. Now coming on to the midbrain. So what are the syndromes we can see as far as the midbrain lesions are concerned? Weber's syndrome is the commonest one we come across, where the patient will have third nerve palsy on one side with hemiplegia on the other side. So if the patient has a lesion on the right side, third nerve will be involved on the right side, where the patient will have drooping of the eyelid, dilated pupil, and medial rectus is damaged. And on the right side, on the left side, the patient will have hemiplegia. And the second syndrome we come across is Benedict syndrome, where the patient will have ipsilateral third nerve palsy. That is, one side the third nerve is damaged with contralateral hemiplegia, and the tremor will be there. In case of Benedict syndrome, red nucleus is involved. The red nucleus is involved, automatically it is said to be a part of the extrapyramidal system. The patient will have an involved movement in the form of tremor. And the third is the pons. You can see here, if the pons is involved, there are two syndromes we come across as far as the pons is concerned. We often say a pontine hemorrhage produces three P's. That's pyrexia, hyperpyrexia, paralysis, and pinpoint pupils. These are the three features of any pontine bleed. But suppose if the patient doesn't have a bleed or an infarct is present, we come across two types of lesions here. One is the Millard-Gubler syndrome, where the patient will have ipsilateral seventh nerve. 11 palsy. This is very, very important, because in all cases of hemiplegia, facial palsy will present. That's why we don't use the term seventh nerve. If you say the seventh nerve, it is always a lower motor neuron. So in a case of hemiplegia, always you have to say the patient has hemiplegia with ipsilateral facial palsy. But here in Millard-Cooper, on one side the patient will have a sentinel lower motor neuron type of paralysis where the eye will not close with a contralateral hemiplegia. And the second important syndrome here is Raymond-Povelli syndrome, where ipsilateral seventh nerve palsy, horizontal gaze palsy, and contralateral hemiplegia. It's almost similar to Millard-Gubler only, but if the patient also has a gaze palsy, you have to depict that the patient has a Raymond-Povelli syndrome. And now coming on to the medulla, there are two important syndromes here, Wallenberg syndrome and that's the lateral medullary, and second of course is medial medullary syndrome. So if the lateral medullary syndrome, the lateral medullary tegmentum is involved, then now the 9th and 10th are involved, where the patient will not be able to swallow even a single drop of fluid also. Suppose that if you pour some amount of fluid into the patient's mouth, usually they'll be choking, and sometimes the patient can die of aspiration pneumonia. So if the 9th and 10th are involved, it is known as a Wallenberg syndrome with contralateral hemiplegia. And if the 12th also is involved on one side with contralateral, this is known as medial medullary syndrome. So I am not going to the depths of the subject here, because as far as undergraduate is concerned, if you know that the Wallenberg cell is lateral medullary and medial medullary, in lateral medullary, the 9th and 10th are involved. In medial medullary, the 12th is involved. That's more than enough. When the 12th is involved, automatically the speech disturbance will be definitely present, because the important function of the tongue is the speech, not taste. Now coming on to the lesions in the spinal cord. Now the spinal cord begins at the cervicomedullary junction and ends at the condylar's medullaris. On the right hand panel, you can see a beautiful diagram where it starts at the cervicomedullary junction and down below it ends at the cornus medullaris. The anterior and posterior roots form the spinal nerves, and they are segmentally arranged in 31 pairs. And the 31 pairs are cervical 8, thoracic 12, that comes to 20, lumbar 1, lumbar 5, sacral 5, that comes to 30, and coccygeal 1. So 31 pairs of cranial spinal nerves are present. The length discrepancy between the spinal and the spinal cord during the developmental stages, it creates a difference between the segments of the spinal cord, because the vertebral column usually grows much beyond the spinal cord. That's why it's a blessing in disguise for the human beings, in the sense, if it is not so, we'll not be able to perform a lumbar puncture at all, because the spinal cord usually ends at the level of upper border of the L1. So you can go safely for a lumbar puncture between L2 and L3 or L3 and L4, where you'll get only the cauda equina, spinal cord is not involved. If the spinal cord is damaged, rest of the life the patient will be paraplegic. So the vertebral level that progressively increase from rostral to the caudal, and the spinal cord has two major enlargements of the cervical, which are comprised of the brachial plexus, and the lumbar region, which comprises the lumbar plexus. The upper end is continuous with the medulla, and the lower end is continuous with the conus medullaris, which becomes the filum terminale. You can see the cauda equina diagram here, and the spinal cord on the right hand panel. The internal structure, well, a cross section of the spinal cord usually gives you a central gray matter, which is H shape. This is known as H shaped area or the gray matter, and it is referred to anatomically as anterior and posterior horns, the dorsal horns and the ventral horns. So anatomical pathways or the motor pathways are most easily recognized. That's why if at all a motor pathway is damaged, the patient will have pyramidal signs, and they are identified till the conus. The tract is identified till the conus. And you come to the sensory pathways, fine touch, 2-point discriminations are carried in the gray side and the cuneate fasciculae on the same side of the spinal cord. And these are referred to as the dorsal columns, and the sensation is known as the dorsal column sensation. The other sensations are joint position sense and vibrations. All these are carried in the posterior columns only. So fine touch, vibration sense, position sense, joint sense, 2-point discrimination, all these are carried in the posterior column. They are known as the gracile and the cuneate nuclei. Pain and temperature and touch are carried in the spinothalamic tract, and we have two tracts, lateral spinothalamic and anterior-spinothalamic tracts. And pain afferents enter the spinal cord. They ascend 2 or 3 segments before they cross towards the other side. So pain afferents, they usually enter the spinal cord, they ascend 1 or 2 segments, and then they go towards the opposite side. So this is a false localizing sign because a lesion at T3 may cause signs as low as T6. So you have to add 3 in the thoracic region and above in the cervical region, 1 in the lumbar regions 2. So if the patient has a lesion at the C4 or 5, the so-called signs will be present just below it or 2 segments below it. And if a lesion at T3 may cause signs as low as T3, and a lesion at T6 can produce signs as low as T9 also. These are known as false localizing signs. As you can see on the right-hand panel, I have depicted. So the fibers usually cross towards the opposite side. They ascend 1 or 2 segments. And what are the spinal cord syndromes we come across? One is complete transectional spinal cord. This is often known as transverse myelitis, a post-viral illness where the patient is brought in a paraplegic state, where the complete transectional spine, it may produce a paraplegia if the lesion is present in the thoracic region, and it can produce a quadriplegia if the lesion is present in the cervical region. This is known as complete cord syndrome, where loss of all the sensations and voluntary movements below the level of the lesion will be present. Bilateral lower motor neuron paralysis and muscular atrophy in the segment of the lesion. Say, for example, if the lesion is present at T4, at that particular juncture, we have a lower motor neuron type of paralysis, and below that, we have bilateral spastic paralysis below that lesion. And the patient will have sensory loss of all modalities below the lesion, and loss of bowel and bladder sensations, and a plantar extensor response. So you can see here in the diagram where the entire spinal cord has been damaged. A section of the spinal cord completely is damaged, and a plantar will be extensor. And what is anterior cord syndrome? So, for example, if the antispinal artery is damaged, usually you'll get anterior cord syndrome where the posterior part of the spinal cord will not be damaged. See here, the patient will have bilateral lower motor neuron type of paralysis in the segment of the lesion and the muscular atrophy. The patient will have bilateral spastic paralysis below the particular lesion. Bilateral loss of pain, touch, and temperature below the lesion because the spinal thalamic tract is situated anteriorly and laterally, but not posteriorly. And a tactile discrimination and vibratory and proprioceptive sensations are preserved. So because the posterior columns are the ones which usually carry these sensations. And what is central cord syndrome? Where the anterior part as well as the posterior part is not involved, and exactly the center. Intramedullary tumors, say for example, if a tumor is present intramedullary, then you can get a central cord syndrome where the peripheries are not damaged. Exactly in the center, it will be present. Most often is caused by hyperextension of the cervical region of the spine. So this is often known as a whiplash injury, where the spine will be extended and will be forced to go towards the front. Most often, suddenly, if a car is speeding at a part of move, but in such a way, there will be extension and a forward flexion, which produces a whiplash injury. And the cord is pressed anteriorly by the vertebral bodies and posteriorly by the bulging of the ligamentar flap. This causes damage to the central part of the spinal cord. And the third important thing is we often teach you in the physiology itself, the Brown-Sequard syndrome, where hemisection of the spinal cord, one half of the spinal cord on one side is damaged. So here, the patient will have ipsilateral lower motor neuron paralysis in the segment of the lesion, and the patient will have muscular atrophy, and ipsilateral spastic paralysis below the lesion, and Babinski sign on the side of the lesion. And you can understand, on the side of the lesion, the patient will have muscular atrophy and paralysis, and ipsilateral spastic paralysis and Babinski's sign. Apart from that, the patient will all have sensation to be lost on the other side, because the spinal thalamic tract from the opposite side will come towards this side in the spinal cord. So ipsilateral loss of tactile discrimination vibratory sense and contralateral loss of pain and temperature sensation below the level of lesion, 2 or 3 segments below. As you can see here, it's neatly depicted. If you see the blue panel, it is complete involvement of motor system. On the other side, it is the spinal thalamic tract. It's depicted in the purple region. And what is a syringomyelia? It's a developmental anomaly and most commonly affects the brainstem and cervical region of the spinal cord. And there is a cavitation and gliosis at the central region of the neuroaxis. You can see here a beautiful diagram I have depicted. This is the one where you can have the syrinx, and this is the part which is damaged. So here a diagram where the loss of pain and temperature sensations are present. So a cape-like distribution of loss of pain and sensation. Cape is a jacket. You can see here a sleeveless jacket is known as a cape. The banian wear, males wear a banian that is known as a cape, and half of this is involved where the patient will have loss of sensation over the neck as well as over the body on one side. This is known as dissociated anesthesia, where the patient's pain and temperature will be lost, but posterior columns will be intact. And what is subacute combined region? This is often we see in the courts, and there are people who are known as vegans, where they won't even take egg, they won't even take non-vegetarian food, they won't even take dairy products. So these people are said to be vegans, and people, it is said that vitamin B12 levels in the liver, they last for only just 3 years. And once if they're lost forever. So if the patient comes to you with a disease known as subacute combined degeneration of the cord, always you have to search for a vitamin B12 deficiency. Here, the patient will have a loss of posterior columns, they're damaged, and the fine touch and vibration joints are lost, sensory ataxia will be present, and absent deep tendon jerks. But because of the involvement of the pyramidal tracts, a plantar will be extensor. This is irony, where when we teach you, we say upper motor neuron will produce exaggerated deep tendon jerks and a plantar extensor. But this is one condition where the deep tendon jerks are absent, but the plantar will be extensor. This is known as SACD, or subacute combined degeneration cord, due to vitamin B12 deficiency. So this is my last slide, a take-home message. Occam's razor, or the principle of parsimony, states that the most likely solution is the simplest. See, neurology is said to be like mathematics, where 2 into 2 is 4 only. So if you know the anatomy of the nervous system, it is very easy for you to depict a lesion. The least complex diagnosis is most likely to be correct. So don't go for a complex diagnosis. The least complex diagnosis is most likely to be correct. Never make 2 diagnoses when one will do. Don't go for a lesion in the spinal cord, a lesion in the brain, lesion in the cerebrum. You should be able to depict the lesion only in exactly one place. And a common error in diagnostic reasoning is accepting a diagnosis before it is fully verified. That's premature closure. So you won't examine the patient in total. So if you examine right from top to bottom, take your own time, then you can go for a very good diagnosis. Thank you very much. Thank you, Vishnu. So friends are the ones who set you free from all challenges of life. Right? This is for your friends. Thank you, Vishnu.
Thank you so much.